Next paper will be given by Dr. Mandal, the 1014 French Silicone Foley Catheter used as the standard device in reconstruction surgery.
Hello. Respected Chairperson, my colleagues here. The title is 10 or 14 French Silicone Foley Catheter used as expanded device in lid reconstruction surgery. Author and the co-author have no financial interest. In this study, the temporary expansion of the skin muscle soft tissue complex at a time expanded tissue used in general rotational flap or scar revision surgery. In 2019, we first introduced a 10 or 14 French silicone Foley catheter used as an expanded device. Skin stress relaxation property is the basis of the tissue expander. Stress relaxation, once the force has been used to stretch the skin, a decreasing load is needed to maintain the stage over time. Fric is increasing the rate of skin extension when this constant load is applied to the overtime. Objective of this study to evaluate the efficacy of 10-14 French silicone catheter. The skin is supposed to expand in the repair of upper and lower lid reconstruction after a large tumor, trauma, scar revision surgery with full thickness skin grafting. To evaluate the cost and safety of silicone Foley catheter rather than conventional silicone tissue expander. To assess the anatomical, cosmetic, and functional outcome of the reconstruction disease. Ethical committee approval was obtained. The prospective non-comparative interventional study of 34 patients over 3 years. The inclusion criteria are all upper lid malignant tumor, lower lid upper lid created defect 40 to 70%, sometimes 100% after removal of the tumor, upper and lower lid cicatricial ectropion with cicatricial. Exclusion criteria involving the local lid, distant aggressive liver large vein, associated with adequate movement, corresponding lid fracture. In lower lid created defect, the means is 58.5 with the standard deviation. Upper eyelid, it must be to 5.9 with standard deviation. Preoperative pelvic fissure height in upper eyelid, means 4.8, and postoperative pelvic fissure height 9.6. Preoperative LPS section upper lid tumor is 5.1, and the LPS section postoperative after 6 months follow is 13.7. Preoperative MRT1 in upper lid tumor is 1, postoperative after 6 months 3.1. The basal diameter of the ellipsoid area of expansion in the upper lid reconstruction mean 4,250.77 with standard deviation square millimeter. Lower lid is 4,251.90 with standard deviation square millimeter. Scar for revision surgery is 5,574 square millimeter. Mean initial length in expander 70 with standard deviation. Mean proposed initial length without expander is 111.2. The reduction of the initial length is 63%. Cosmetically better look. Rehabilitation is much better. Break lip faces result in all the cases. There is no such complications. Now, first to see where the calculate is. This is the ellipsoid area, where A is the square surface area, which is A equals to pi, what is 3.14. A is long axis, expressed in millimeter, and B is the short axis. Now comes to how to do it. This is the tumor, lower lid penetrating carcinoma. First we have to expand. Ellipsoid area is marked in the jargon for temporal region. So single axis dissection. It starts from the long axis of the ellipsoid area. It goes over the periosteum, over the bone, and a skin muscle complex should be expanded instantly, simultaneously. The catheter goes 1 centimeter beyond the level of ellipsoid area, then expanded. Skin muscle complex expanded for 3 days. On 4th day, we deflate the balloon. Once the balloon is deflated, we instantly do dissection of the tumor, almost 100% created defect. It is not possible by a tendril rotational flap. As the tissue is expanded, we take the advantage of this relaxed tissue. Instantly rotate the flap medially This heavy flap fixed over the periosteum with a 4-channel rolling suture to prevent the derotation of the flap. After that, we make the newer cancers, but it's 30 millimeter calcium aperture, which is in normal. New cancers form. This is a 30 millimeter length. After that, we give a reinforced suture in the lower eyelid to prevent the notching of the lower eyelid, because this is a notching of the reinforced suture. Then after that, now you see, this is the design of the incision. This patient needs muscle D, but with the expander, we use only radial rotational flap. This is a scar revision surgery with a lower lid cicatricial ectropion. This is the scar revision surgery. Again, where the MRD value is much higher. Then again, you mark this ellipsoid area over the bony surface. Again, the same procedure, inflate the skin muscle complex at a time. Now the balloon is inflated again for 3 days. On the 4th day, deflate the balloon, make an ellipsoid area of skin defect where all the scar is removed. As this ellipsoid area is created, the lower eyelid bulge goes up. So the MRD2 value will be reduced, and the full thickness skin grafting done. The skin harvested from the medial surface of the arm. This is the full skin grafting done. Now this is the patient. The patient having MRD2 value increase after operation. It is cosmetically accepted, and MRD2 permitting the closure of a larger eyelid defect 100% typically not possible in the cranial flap. It is flap for declination, minimal dragging force required to rotate the heavy flap. The suture line tension is partly reduced, thereby improving the sensitivity, limiting the vision for weeks or months, that is you got a layer of huge transparent flap. Incision length is also reduced compared to conventional cranial flap, which is 63% reduction in length. Limitation of this study, 10-14 French silicone catheter is 4-dimensional expansion rather than a conventional expander. So it is only applicable over the periosteal surface. One of the surface will be hard against the bony surface. Comes to a conclusion, the effectiveness and applicability in the cranial flap for full thickness grafting can be increased with the actual use of tissue expander. This is successful application of mobile surgical approach for eyelid reconstruction. The tumor necessary utilizes 10 or 14 French catheter. The successful results of this novel usually makes a reasonable, more cost-effective option in the United States and other developed countries. The author believes that this makes it an excellent tissue expander in underdeveloped world where access to other more expensive expanders are limited. Thank you.
Are there any questions?
Congratulations, very nice presentation. I have got a few questions. Number one, that we are doing a tumor, and when we were excising the tumor, have you used frozen
Yes,
section? It has
this
been
is mandatory. Any tumor when you remove, frozen section is mandatory.
That's number
We are
one.
not
And
concerned about the frozen section.
yeah,
We are
no,
doing the
because with the frozen section, you might what you planned, it might be a much larger at the
frozen
end of the
section.
surgery.
In any malignant tumor, frozen section is mandatory.
Okay.
Without frozen section, you can't do it.
Okay. Second question: what is the fluid that you're using for expansion?
Normal.
Okay.
You
Then
can any fluid. Normal saline, distilled water, any.
yes.
Even if it's
So,
a
what
bad
is
balloon
the?
bag.
Do you have any post-operative contracture of the expanded tissue? Because since a saline has been used, and usually the saline, once it is being released or it gets absorbed, the contracture is always there. So that is one of my question. And secondly, why do you think that this is a better technique than the tip ears or the fixed flap, which we use when we cannot use a tinsel?
Your first question. Normal saline have no contact with your tissue because it is in the balloon. Normal saline is not contact with the tissue, it is in the balloon. So you can use air also, but air tamponade effect is not good. So there is no question of contact. we can take the advantage of the relaxation of the tissue. Either any way, you expand expand it. And you take the advantage of the relaxation temporarily, not permanently. That is why I need 3 days expansion. On the 4th day, we remove the tumor and instantly rotation. And your last question, the last question. Oh,
Overprints
yes,
and the
I
tears
will.
there.
When the 100% is defect, the lower lid, massage the cheek rotation is the rule. We try to avoid after the cheek rotation because most of the facial nerve is cut. So we use expander with a minimal incision length and maximum output. That is our objective. So the result is this. And also the hypothesis that if you expand the tissue, the blood flow is increased and neovascular is increased. I am really astonished after doing a full thickness skin cavity. It's none of the cases fail. Any question, anyone?
The difference how long it is, like the chronicity of the scar. Say for example, a patient
The
has a
scar,
tumor
scar revision
10 years
surgery.
ago. Yeah.
Scar revision surgery. If the patient comes to us, the scar revision for burn, acid burn, it comes to me. We just do a scar revision surgery with a full thickness skin gum. It is not that expander used for scar revision surgery. We do an ellipsoid area that makes the MRD to swell up and make a ellipsoid area. That area is covered by a full thickness scar, which is harvested either from either from the arm or the abdomen. To understand, harvesting skin from other side to replenish the own defect, deflated defect that will cause your scar revision surgery. Scar means a tissue deficiency. You have to supply tissue anyway, either to expand that, just with the relaxation of the tissue, then also tissue harvesting from anywhere. Any question?
Any other questions? Thank you very much. Our next paper will be given by Dr. Schneider, dermoscopy